Good afternoon, everyone. I'm Paul Bergantino from Lifeway Mobility, and we're your host for this approximately 30-minute session today. Lifeway services Southern New England. We provide solutions in two key areas, accessibility and safe transfers. So when I say accessibility, I'm referring to helping individuals overcome architectural obstacles, such as stairways, navigate around bathrooms, etc. So we provide products such as ramps, stair lifts, and bath safety to fulfill these accessibility needs. Our other primary focus is safe transfers. So helping transfer someone from a bed to a wheelchair, on or off a toilet, in or out of a car, up from a floor. So these solutions are geared towards the caregivers and clinicians. We provide products for active, semi-active, and passive patients. And we can help you with both these transfer and accessibility needs. We provide free assessments, so if you have any needs, please call us or contact us today. Our seminar, as I said, is about 30 minutes. It's titled Safe Patient Handling and Mobility Basics. Our presenter has experienced a serious back injury herself while transferring a patient. She's a clinician and a safe patient handling and mobility subject expert. She has provided training throughout the country. I'm excited to introduce Amber Perez. Amber?
Hi, welcome to the webinar. So this morning, as Paul mentioned, I'm going to go over the safe patient handling and mobility basics. This is for those of you that maybe are new to the industry, or you've been working in healthcare for quite a while, and maybe this is an initiative that is being presented to your organization, as it is to many. So the first question you might wonder is, what is safe patient handling and mobility? It's using the principles of ergonomics to safely perform the lifting and mobility tasks of healthcare. Now that's the definition. When you think of ergonomics, when I first heard this definition, I thought, what does ergonomics have to do with healthcare? And in my mind, I used to think ergonomics as far as a workstation, or how somebody sits in an office chair, or preventing carpal tunnel syndrome. I really didn't think of ergonomics as something that applied to the healthcare setting. But really, when you look at what ergonomics is, it's the study of how a job fits with a person. So many years ago, ergonomists were invited into healthcare to really address why we were seeing an increase in injuries, which I'll talk about in a little bit now. And they really wanted to study, does the job fit with the person? And that's really what we want to look at today. We know that safe patient handling involves equipment, some of which I'll talk about today, other tools, nursing and physical therapy assessments, and all of this knowledge translated into the daily tasks involving patient handling. We know that safe patient handling is safer for the healthcare professional, but it is also safer for the patient. We know that it improves patient mobility and patient outcomes. So why safe patient handling? Cumulative injuries are very difficult to calculate because many are underreported. And when I talk about cumulative injuries, this is something that occurs day in and day out. If any of you out there are bedside healthcare workers, you think about if you work a 12-hour shift, the last 3 hours of that last day, your back's a little sore, your neck's a little sore, but it's not enough that you might report that you have an injury. But over the years of really putting your body through more than your body can handle, you might develop what's called a cumulative injury, where you're putting a lot of assault on the soft tissues day in and day out. And one day you come to the doctor and they say, hey, you've really torn up your body. So this is difficult, as you can imagine, to calculate and quantify. How do we know when the injury occurred? How do we know how many people have a cumulative injury? And how do we know exactly where that injury came from? Well, we're starting to get the data and to be able to see that statistically, these cumulative injuries are happening more often with healthcare workers, and we're able to correlate that it is a result of their job. We also know that our median nursing age is increasing every year. We have an estimated 52% of nurses suffering from chronic back pain. We also know that with the baby boomer generation retiring, we have the largest group of retiring nurses presently, which will then lead to the largest population of aging individuals that we've ever had to care for. This leaves a twofold shortage of nursing and then an increased population to take care of. So that's another thing that we have to consider. How do we continue to keep people at the bedside to be able to take care of the aging population? And finally, putting your health at risk should never be an acceptable work condition. It wouldn't be acceptable to come to work and be exposed to any other risk, to be risk of injury or infection or any of these other things. So we have to start looking at patient handling as a risk and as an unacceptable risk. Unfortunately, it's pretty much been accepted as a norm. When you work in healthcare, you lift, you move, you drag, you pull, you do a lot of things to your body, and unfortunately it has become accepted, and it really shouldn't be. So what about body mechanics, you might be thinking. Many of you in school learned about body mechanics, and this was your primary method for preventing these areas of risk, or really preventing these injuries. Well, we know that body mechanics rely on offloading the weight from your spine and joints and redistributing to your large muscles. So you might have seen pictures like this. Somebody has to bend at the knees, pick up the box. Often the box has handles. You have to pick it up and hold it very close to the body. But we have to think about, does that look like moving and handling people? So in order for body mechanics to be effective, the load must be evenly distributed, held close to the body. It must be static, not move, and the proper position must be maintained. This is why we often have pictures like this, people pushing and pulling furniture and lifting boxes. But that's not what we're doing in healthcare. So think about it for 1 minute. Let's go through the list and think about people. Have you ever met a person who's evenly distributed? So that would mean their head and their neck weighed the same as their midsection, as their ankles and feet. I certainly hope you've never met one of those people. Second, it has to be held close to the body. Well, I know all of you in healthcare love your patients, but we don't love our patients. We don't want to hold them really, really close to our body for many reasons. Number one, it's personal space, it's uncomfortable. But these are ill patients. They often have, they might be vomiting, they might have wounds, they might have reasons where you don't want them that close to your body. So we can't hold them close to our body. The other reason is that they're in a bed. Sometimes you think about you reach into the bed. We can't get the person any closer to our body than we can in this situation. The load must be static and not move. So if we're considering the patient in the ICU, that might be the only consideration when a patient would be static and not move because they are sedated. Otherwise, patients move and they're unpredictable. I like to always point out the example of a squirmy toddler. Most of us have held a toddler at some time in our lives, and when they are getting to that age where they can walk a little bit and they start to get squirmy, if you're holding them on your hip and they start to reach and grab and pull, what do? We squeeze them closer to us because that unpredictable nature, when they're shifting their weight, you can feel it in your back. Well, it's the same with people that we're moving in healthcare. When you start to lift them and transfer them and move them, if they suddenly move or transfer their body weight, it will pull on your body, and that's where some of these injuries can occur. And then finally, the proper position must be maintained. Well, when we put all of the other three considerations together, it's nearly impossible to maintain these proper positions of body mechanics. Now, this is not to say that body mechanics is not important in healthcare. It's absolutely important. We have to think about it in terms of all of the things that we do, not just moving and handling patients. When you push a bed, when you push a stretcher, when you push a wheelchair, when you do lift somebody's leg and it is under a safe lifting limit, we still need to maintain proper body mechanics when we're doing most of the things we're doing. The misconception, however, is that body mechanics will help you be able to lift and move heavy loads when we're talking about moving and lifting individuals, and that's just not the case. So then we think about, why doesn't everyone just use safe patient handling? Why wouldn't they just adopt this and start using it everywhere? Well, let's think about it. This is a change in culture. This is a change in the way that people have been doing things for a long time. Safe patient handling means using equipment. And if you'd been a nurse in healthcare, for example, for 20 years, and somebody comes and says, now you're going to use this piece of equipment to help lift and move your patients, you might have some barriers to change. So let's start thinking about what some of those barriers might be. The number one thing that we hear is, I don't have time. That's going to be pretty consistent throughout every organization, every level of care. People have the perception that using the equipment takes more time. In reality, what we have found, many studies have shown that it actually takes less time. When people think about time, they only think about the time it takes to actually perform the task. So if you look at the gentlemen in the bottom right corner who are lifting and moving that woman, first of all, she doesn't look pleased. She doesn't look like that is a very comfortable way to be moved. They're thinking about how long it took to go 1, 2, 3, go. But they didn't talk about the time it took to find each other, to get in the room, to wait for each other to get set up, and then to move the woman over and get her comfortable. So when we looked at some of these time studies, we realized that when one person uses a piece of equipment, they are much more efficient than when they have to rely on their coworkers. That is not the way I learned to lift, and that we do hear pretty often. And if you go back historically, looking at the way that clinicians are often taught, body mechanics was the primary method for teaching. However, we know now it just doesn't work. The statistics tell us that people continue to be injured, and we'll talk about the statistics a little bit later. I don't know how to use the equipment. That is a very realistic complaint that we will hear as well. If somebody doesn't know how to use the equipment, they're not going to use the equipment. So just getting the equipment is not the complete answer. We also need to make sure that you have the support. And often that support comes from your vendor to be able to make sure that they provide adequate training. The lifts don't fit in the rooms, around the tables. Now we have much more modern equipment. Back when lifts first became available, there was one standard kind of lift. Now we have many options. We have low legs, we have smaller footprints, we have ceiling mounted lifts. So we are able to consider the specific environment to make sure that this works. There's challenges in long-term care and challenges in home care that are also very specific. So making sure that you partner with a vendor that understands your level of care and understands your challenges is very essential to make sure this is not a reason that people won't use the equipment. I've heard safe patient handling doesn't apply in my department or my level of care or my facility. It applies everywhere. Everywhere that people are lifting, moving, handling, mobilizing patients, safe patient handling is important. It might not look the same, but it is important. In a hospital ICU, a ceiling lift is safe patient handling. In home care, a friction reducing sheet or a ladder for a patient to help pull themselves up is safe patient handling. So it's really about understanding what is safe patient handling in my level of care. And then this one, I've never been hurt, so everyone else must be doing it wrong. And unfortunately, I think I was one of those people. And like Paul mentioned, I had been hurt as well. And you don't want to wait until you're hurt to really realize that safe patient handling is important. I didn't realize the risk that I was facing, and many people don't realize the risk that they're taking. When I was injured, I was boosting in bed, so helping a patient move up in bed who was only 160 pounds. And most of you out there who are bedside clinicians think 160 pounds, you could move it with your pinky finger with no help, because our mindset is a little different than most people out there. If you go to other industries, maybe you go to Home Depot and you ask a worker to get a box off a shelf, and that box is 150 pounds. What do? They go get a forklift. They do a team lift. They would never consider pulling a 150-pound box off the shelf. But in healthcare, we see that as a lightweight, and many of you out there are probably nodding your head because that's the way we've been taught to think. Unfortunately, I had a pretty debilitating injury, and as I've continued on in nursing, and I've been a nurse for 13 years, I've seen that the other part of it is you don't know the limitations of your coworkers. So if I'm asking a coworker to help me, I don't know if they have a shoulder injury that they've been nursing at home. I don't know if they have a bad back. So placing my coworker at risk for injury is also something that we need to be considerate of. So is taking risk an expected part of the job? It kind of seems like it is for us. We've been talking about that. Healthcare industry workers sustain 4.5 times more overexertion injuries than any other type of worker. Think about that, any other type of worker. Healthcare isn't something you typically think of as a high-risk job, but the statistics tell us differently. And then according to the national statistics, 6 of the top 10 professions at greatest risk for back injury, nurses aides, LPNs, RNs, health aides, radiology techs, and physical therapists. This is 6 of the top 10 for back injury. So it's really highlighting what I've been talking about, that this is a major risk in healthcare. And we know that greater than 1/3 of back injuries among nurses are attributed to handling patients. This means of all back injuries, of any reason, any person might get a back injury at home or at work. If you are a nurse, it's probably from work. So we know that we've learned to protect ourselves from exposures of other known hazards. And I love this picture because 25 years ago, if you would have told nurses that they would be wearing a gown, gloves, mask to go into a patient room, they would probably say it takes too much time. That's never going to happen. All of the excuses that we hear about safe patient handling. Unfortunately, they've moved over and accepted one culture of change, which was infection prevention, but they haven't really learned safe patient handling in this picture. And I want you to think about what this patient might be going through. Now, she doesn't look very big, and maybe none of these people are injured, although they might be developing cumulative injuries. But look at the way that we move patients when we're not really thinking about it. Do you think her shoulders as an elderly woman really should be lifted in that manner? Do you think maybe all of this repetitive moving to the patient could cause the patient injury? So I want you to think about it not just preventing your injury, but how does manually handling a patient affect the patient? So I want you to ask yourself, do we set inconsistent expectations for safety? When we talk about a culture of safety, most of you that work in any sort of healthcare setting have a culture of safety, and your organization will tell you we have a healthy culture of safety. So safety should include infection control, it should include environmental safety, it should include safe patient handling. So let's think about that. So let's talk about washing hands. Now this is something, if you go into any healthcare setting, every clinician has been taught over and over and over and over that you must wash your hands. This is the best way to prevent hospital-acquired infections or any other infection or the spread of the flu. So would it be okay if your staff said it takes too much time to wash hands? And most of you would say, absolutely not, that's unacceptable. What if they said it's not the way that I learned in school? Right? I learned that you can spray your hands with alcohol and never wash them. That might not be acceptable in your organization. You'd say, no, you still need to wash your hands. Absolutely unacceptable if somebody just said it's inconvenient. I don't feel like it, right? Or I've never seen anyone hurt. I've never seen anyone get an infection, so I don't think it's real. Obviously, that would not be acceptable. But when we look at safe patient handling, it is often the excuses that you'll see that are accepted, and unfortunately leaders accept those. So if they say the same things, it takes too much time, you'll have people in your organization saying, yeah, you know, I really believe that. I believe it takes too much time and we're busy, so we can't be safe. It's not the way I learned in school. I learned body mechanics, and that's what I've been doing for 20 years, and that's what I'll continue to do. Well, the statistics tell us differently. Unfortunately, many organizations accept that excuse. It's inconvenient. I have to look for a sling. I have to think about what I'm going to use for my patient. I have to obtain some equipment. So being safe is inconvenient. And again, I've never seen anyone hurt, so I don't need to do it. And this is often, many healthcare settings leave safe patient handling as a choice, not an expectation for safety. If you don't feel like it's necessary, you don't have to do it. So this is really where we're trying to go with an industry. In the last 10 or 12 years, you've seen a huge shift from personal choice to a requirement. And in fact, 11 states have legislated safe patient handling, requiring that healthcare organizations provide equipment, write safe patient handling policy, and require staff to use the equipment. So we are seeing a shift. Unfortunately, it's not everywhere yet. So we look at the most dangerous jobs in America. This is by Biodynamic Laboratories, and they're looking at the statistics reported by the Bureau of Labor Statistics. This is lost work time due to back injuries, and it's per 10,000 full-time employees. Nursing homes are the most dangerous place to work when you're looking at back injuries. However, next to it, hospital workers. So if you combine nursing and hospital and look at healthcare workers as a whole, it is still the most dangerous. And if you're just looking at hospitals, it is still more dangerous than construction, mining, and agriculture for back injuries. This was really, really surprising to me, and as it is to many of you. Agriculture, if you've ever driven by a field where you have workers out there bent over picking all day long, to me that looks extremely dangerous for somebody's back. You think of what construction workers do. You think about working in a mine in those environments. However, healthcare is more dangerous. So it's something that we really need to be alerted to. So according to the American Nurses Association, 38% of all nurses or nursing assistants will have a musculoskeletal injury that results in light duty absence or long-term disability. That is more than 1/3. And what we often don't think about is, what is the effect of an injury outside of that person being injured? I can tell you and probably talk to you for the next 30 minutes about all of the personal effects of the injury, but what about the effects for everybody else? So I want you to think about where you're working or where your healthcare environment is. If 1 in 3 of the people that you work with were not there, what would your day be like? Would it be okay if we had a registry nurse come in and replace that missing nurse? Would it be the same? If you work in a home care environment, are there 3 of you? If 1 in 3 of you went missing, could you take on the caseload of the other people? And then think about if you are the caregiver and you're caring for a family member and you're the one that gets hurt. Who takes care of your family member then? How is this possible? So this affects all of the different settings, all of the different dynamics that we could be thinking about. And losing 1/3 of our people is really just not acceptable. So the other issue that we're facing is an epidemic of obesity. Unfortunately, this is getting worse, and this is often the area that people do tend to think about safe patient handling. Safe patient handling should be thought of for all of our patients, but these are the patients that we know present the highest risk. So when we're looking at the CDC chart, this is 2011. Now, the green is 20 to 25% of the population is considered obese, and if you go to the yellow, 25 to 30%, then the orange is 30 to 35%, and the red is greater than 35%. So in 2011, we had some states that had 30 to 35% obesity. 2012, we got more of those states, and more of the green turned yellow, so it seemed to be getting worse. 2013, we saw 2 states that had greater than 35% obesity. And in 2014, we added another state. So you can see that the trend is just getting worse. It's not getting better. And we need to be able to be prepared to respond to this in every level of care. In the acute care setting, obviously we need to be able to have the beds, the ceiling lifts, but these patients are not limited to the acute care setting. With all of the changes in healthcare reform, we know that we will see more acutely ill patients in lower levels of care. So long-term care, nursing home, Medicare, rehab facilities will see more bariatric patients. And then it will translate to more patients at home. So again, we have people that say, I've never hurt myself. Many healthcare professionals are resistant to safe patient handling because they believe they have never hurt themselves. And I love when I hear people saying, you just need to work out. Well, we're going to talk about why that doesn't help everybody. Yes, working out is important, being strong and healthy is important, but let's think back to those principles of body mechanics. And no matter how strong you are, will working out help you? And the answer is no. What we know is that NIOSH, the National Institution of Occupational Safety and Health, they recommend a 35-pound weight limit for lifting patients. They know that greater than 35 pounds is known to cause tears and scarring of the spinal tissue. So just in case you didn't know, the general OSHA recommendation for all industries is 51 pounds. The reason that it is lower for healthcare is because of all of those reasons we talked about with body mechanics. Uneven distribution of weight. You can't hold the patient close to your body. They move. So with all of those factors, NIOSH said we have to lower the weight limit to be safe. Now, the picture that you're looking at here is a spine, and we're looking at the vertebrae. So the top and bottom are the vertebrae, the bone, and in the middle is the disc. So if you look at the part that says vertebral end plate, that is the end of the bone that meets the disc. And what we know is that there is no blood supply going directly into the disc. So there are no capillaries or veins that go directly into the disc. All of the fluid and the nutrition and everything that that disc needs comes through diffusion through that vertebral end plate, which is a very thin part of the bone that allows for diffusion. When we manually lift greater than 35 pounds, we see microfractures on those end plates, so tiny breaks on the plates. The fractures are healed with scar tissue, but eventually that scar tissue leads to cartilage buildup. The results are long-term disabling back injuries, disc degeneration, and spinal stenosis. And remember earlier when I said those cumulative injuries, this is the result of those cumulative injuries. So if you look at the pictures here, this is a picture of an autopsy looking at the spinal end plates. And the arrow pointing to the healthy tissue, that's what we want the end plate to look at. But when we look at the scar and the cartilage, you can imagine that you cannot have the diffusion of the fluid and the nutrients into the disc if you have all of that built-up barrier. This, unfortunately, is what many healthcare workers' spines look like after 20, 25 years of working in healthcare. And this is something that can't be fixed. There is no end plate replacement surgery that we know of yet. And what ends up happening is those discs shrink, they don't have the fluid needed in them, and they start compressing on nerves. This can cause disability. This can cause somebody to be wheelchair bound, to be on chronic pain medications. And this is something we have to think about now, because if we don't start preventing these injuries now, they will accumulate into something like this. When you hear about the major back injury, my back injury, I burst a disc in my thoracic spine. It was terrible, but I had physical therapy, I had my disc refilled, and I'm doing fine. I'm aware and I'm very safe and I take care of my back now. That's something that none of us want to have happen, but it can be corrected. This cannot be corrected. And this is what we're starting to see now after people have spent years and years and years working in healthcare. And it's something that we really want people to be aware of so that they know that this risk is out there instead of waiting until they retire, you know, earning for all of those years, hoping to maybe travel and do some great things after they're done working, but finding out that they have chronic back injury and chronic back pain. So we think about how do we prevent these injuries? We've talked about the risk, we've talked about these injuries. So we're going to talk about some of the safe patient handling solutions and why safe patient handling and mobility is a movement now. Let's look at the frequency of tasks. Now, the only table I have is talking about acute care, but you can think about that, you know, actually in long-term care, it's even more, and in home care, it can be more or less depending on the task. So when we're looking at a 300-bed hospital, and this is an estimation of a 24-hour time period, on average, there will be 800 patient boosts in bed. That's because it happens multiple times. Most of you that work at the bedside, you know this is probably something you do more than anything else. You go in the room, they've got the hospital bed, they sit the hospital bed up, it slides them down the bed, you lay them down, you boost them up. So 800 times a day. Think about the cumulative injury on your back. Turning and holding patients for various reasons. You do it for wound care, you do it for bathing, for placing bedpans. Lateral transfer, 180 times. This is when we move a patient from stretcher to bed, stretcher to stretcher, stretcher to OR table. So any movement from a lateral surface. And that little picture there, you'll see that's pretty much what it looks like. Somebody's reaching and they're pulling. To and from out of bed, 420 times. So from bed to chair, chair to bed, back and forth. And again, chair to bed. And then stand assist 300 times, whether we're just standing for therapy, standing and pivoting, standing from bed to chair. Ambulation assist about 40 times. And then we don't have all of the numbers for limb holding, in and out of a car, falling, recovering a patient from falling off the floor, because those vary within facilities, but we know those are also high-risk tasks. So when we put them all together, there's about 2,440 tasks that take place all day long in a healthcare facility. And if you just started to think about the risk of injury and how many potential injuries we could have, none of these people are using the proper equipment. We've really got a big problem on our hands. So let's look at it based on the setting that you're in. So if you're in acute care, you might be doing early mobility, and that's getting patients up and out of bed early. It starts in the ICU. New research tells us that this is good for the patient. So you might be assisting in early mobility, boosting in bed, like I just talked about, repositioning and turning. The National Pressure Ulcer Advisory Panel tells us to turn our patients every 2 hours. So that's something that you're doing all the time. You're doing a lot of bed pushing or stretcher pushing, getting patients between units, getting them from their x-ray back up to their room. Limb holding. This happens in multiple departments. Labor and delivery, it happens all day long. We have limb holding for surgery. We have limb holding for wound care, for range of motion. Transferring from bed to bed or out of bed, obviously something that happens every time a patient has to get up, use the restroom, eat a meal, go to therapy. Bathing. This can happen in the bed or it can be in the shower room, but it's also a very heavy task. Changing an occupied bed, and then all of the tasks with therapy. Those are some of the risks you have there. Long-term care, some of the similar risks, but a lot more bathing, dressing a patient. Many of their activities of daily living, we're trying to rehabilitate these patients often and get them home. So you're trying to recreate some of those daily activities. And so you have to get them up, get them to the sink in the mirror. They have to brush their teeth, get them back to bed. You have a higher proportion of dependent patients. And this is very true. Oftentimes the patients who do not do well in therapy or do not meet all of their goals required to discharge will go to long-term care. And it's not always permanent. It's sometimes a short-term stay, but that's where most of these more dependent patients go. So when you look at the proportion of dependent patients in long-term care to acute care, you have many more dependent patients, which is much more risk for the healthcare staff. And remember, the most dangerous jobs in America, nursing home was #1 for that reason. We're also seeing more long-term care bariatric patients. These larger patients, the obese, and the new category of the super morbidly obese, are becoming more and more prevalent in long-term care, and they have the needs of every other patient, except the risk is much greater. Therapy tasks are very heavy in long-term care. You've got rehabilitation. A lot of facilities are Medicare rehabilitation facilities intended to rehabilitate the patients, and they have to be up every day. They have to be out of bed 2 to 3 times a day. So you've got a greater risk of exposure there. And then another challenge is that you have elderly patients with fragile skin. So moving and handling patients manually may expose them to more risk of skin tears. When we can control how the patient's moving with equipment, it's much safer for the patient as well. So in home care, we have hospice, home hospice. So you have a very dependent patient who needs a lot of care and a lot of physical movement. We have home therapy services, PTs and OTs that are in the homes doing therapy. We do bathing, wound care, dressing. Some of the other challenges are the furniture and environmental barriers. We know that in home care, they don't often have the bed that will sit up. We don't often have some of the higher toilets. So getting a patient out of a bed is a much more dangerous task in the home care setting than it would be in a hospital or long-term care setting. So there's a whole set of unique challenges there. So this is just an example of some of the safe patient handling and mobility equipment that we can use to help mitigate some of these risks. We have lifts, and they can be ceiling lifts or mobile lifts, and these are total patient lifts that will help move and transfer a dependent patient. Slings go with the lifts, and they help us move the patients. Many different kinds of slings. They can be anything from a sling you see here, which is a hygiene sling that can help get a patient onto a toilet, to a sling that offers head support for a patient who has no head control. A rollerboard is a great tool that helps us move a patient from bed to bed. Slide sheets are friction-reducing devices. They help us boost patients in bed. The safe handling sheet and the limb sling are both accessories for the lifts, and they will help us boost a patient, turn a patient, transfer a patient. And then the sit-to-stand lift is for a patient who can bear weight but maybe doesn't have the ability to come to stand on their own. So when we talk about out-of-bed mobility, we can use, like I mentioned, the ceiling lift or the floor-based lift, and they can translate into many settings. There are special lifts made for the home environment that can even collapse and be pushed under a bed. There are lifts made for the long-term care environment that have a higher weight capacity, that are durable, that will last through many, many years. And then, we have ceiling lifts that are intended for maybe the ICU setting, but we also are starting to see ceiling lifts even put into the home care environment. If you have a long-term disabled patient, a ceiling lift might be the best option so that all caregivers have a chance to make sure that they can take care of that patient. The sit to stand, like I mentioned, helps a patient who doesn't have the ability to come stand on their own, but we have different versions and different varieties. What you see here in the top left is a mechanical sit to stand, and the other two are non-powered stand aids. So this is more simple. It might be more appropriate in a home care setting, a long-term care setting, but we're definitely seeing these in the acute care setting as well. As the patient starts to progress, we want to use less equipment so that they can do more of the movement and the work. They're easy to use. You use them, wipe them down, put them back. They don't take, the bottom two don't have batteries, plugs, slings, so it's just something that is a little bit more efficient. When we're turning and repositioning the patient, this is a picture of a safe handling sheet. Depending on your lift, we have lifts that can lift up to 1,250 pounds. And this means one or two caregivers can safely lift, boost, and transfer these very large patients without requiring many people to come and assist. Like I mentioned, the lateral transfer, that's a picture of how the roll board is used. There's a piece of fabric that goes circular over the board, and as you push or pull the patient, it helps slide them to the other surface. So you're really not expending as much strength to push them or pull them, and you're reducing the risk for both you and the patient. Ambulation, so walking. This is something we definitely want to have a solution for. We want to get these patients up and out of bed. We want them to walk and get stronger, but we do not want the patient to fall. I think that's the thing that we're most worried about no matter what setting you're in. So knowing that there are solutions for this as well is very important. We can do anything from what you see on the left, a walking sling. It can go on a mobile lift, or it can attach to a ceiling lift. And what you see on the right is a safety walker. It's called a row walker. It's a platform walker. It can carry all of the patient's accessories, an IV pole. It has a basket for accessories. Their oxygen tank can be put in there. And there are safety seats. So if the patient walks a couple feet down the hallway, they get weak and tired, I don't need that second person following behind the wheelchair or following behind with the wheelchair. The patient can just have the seats lowered and sit down. So again, more efficiency. I'm not requiring as many people to do this, so it actually takes less time. So you think about what can you do? How can you get started? Well, first, definitely ask, how are we assessing our patient's mobility assessment, mobility status? There are nursing mobility assessments out there. I'm happy to share with anybody who's interested in learning about a nursing mobility assessment. And this is something that will help a nurse assess mobility, which isn't typically taught in nursing schools, and assign the appropriate equipment so that we know a dependent patient needs dependent equipment and a minimal assist patient maybe just needs a gait belt or a lower piece of equipment. We also need to determine whether equipment is needed on admission for every level of care. So whether you're a home care nurse and you have a new hospice patient, or you're working in long-term care or acute care, part of the admission record really needs to include what equipment do we need to safely move this patient. It needs to be recorded, it needs to be communicated so that we have that consistency to prevent that risk of injury. You need to know your safe patient handling policy. You need to know if you're in a state that legislates safe patient handling. What are your rights? Should you be protected? Most healthcare organizations in the acute care side have a safe patient handling and mobility policy. Long-term care is getting there, and many of them have a safe patient handling and mobility policy. Home care is coming. I'm working on a project right now with a really large hospital system who asked me to help create a policy for home care. And I think really this is going to set the stage for more and more home care addressing this and making sure that we're preventing the risk there as well. Everybody needs to work as a team. If you're not communicating what the patient's transfer needs are, then we're placing other people at risk. So if you think about that, you know this patient needs a lift, but then you send them to radiology, that needs to be communicated because that radiology staff is also at risk for injury. So looking at everybody as a collaborative effort to protect the patient and protect yourself. And then ask about the solutions that are specific to your level of care, like acute care, long-term care, home care, and then your specific discipline, orthopedics or hospice or therapy. Your vendor has these resources. If you maybe don't know that there's a solution, or maybe you are thinking about a specific patient or a specific situation and you're thinking, I don't think that there's anything out there that can help me, that's when you need to partner with your vendor. That's what the vendor does all day, every day. And they have the resources to be able to find out, how can we solve this problem? Because if you've had a problem, if you have a high-risk situation, if you have a patient that's difficult to move and transfer, somebody else has to. And then I always say, when in doubt, choose a safer route. Use a lift even if you're not sure, because nobody's going to get hurt. If you meet a patient, you don't know how they move, be safe, use safe patient handling equipment. So that is it. That is the end of our presentation, and I just want to thank everybody for attending. And if you have any questions, please feel free to contact Lifeway Mobility, and they'll be able to answer any of your questions or provide you with some of the resources that we talked about today.